All right, class, this is the Psychotropics Pharm 1 Module 3 PowerPoint. You'll be using this content for week 4. A lot of the information that I share with you in this PowerPoint should be familiar, as it should be the same exact information as you are hearing in mental health. You guys will be applying this information more in mental health, so I highly recommend that you study both mental health and pharmacology together. Next slide. Class, I want you guys to understand what it means if you have a serotonin or selective serotonin reuptake inhibitor. If we are blocking the reuptake process, then we are allowing the body to use more. Meaning, if we block, and you can see here, this is the SSRI blocking the reabsorption of the serotonin. Now you see the receptor sites here. Remember, these are your cups. We can fill more of our cup and multiple cups if we block the reuptake of it. This is a very important concept to understand because there's a lot of different drugs that. Another way you might hear this is if something increases the uptake of norepi, dopamine, serotonin, and tyramine in your MAOIs, then they're saying that they're increasing the uptake at the receptor site. Reuptake means that it is coming back to the brain. Okay, let's move on to the next slide. This section discusses the neurotransmitters, or your chemical messengers. You guys need to understand what they do, or at least the basics, because this will help you to understand the mechanism of action. If something is going to, if something is an agonist for an epinephrine neurotransmitter, then we know that that's going to increase cardiac output and blood sugar and help to communicate, help the neurons to actually communicate more effectively with one another. You guys understand the concept of dopamine. So once again, if it interacts with the dopamine agonist, then it's going to increase the heart rate and cardiac contractility. And it also has a lot to do with how we feel pleasure. In reference to the previous example that I gave you guys about the uptake of norepi, dopamine, serotonin, and tyramine receptors, that is what your MAOI enzymes in the brain do. So if we block the MAO enzymes in the brain, it's going to increase the uptake of norepi, dopamine, serotonin, and tyramine. And if you look on my paper here, we've got norepi, increases heart rate and blood pumping, helps mobilize the brain for action, improve energy. We've got dopamine, which we talked about was how we feel pleasure, increases heart rate. We've got serotonin, which is a big role in mood, emotions. It can help regulate your sleep and the body clock. And then your tyramine helps the brain and nervous system function normally. So if you look at those 4 enzymes being more, if you look at those enzymes being able to be absorbed more because we are blocking the reuptake, or we're blocking the brain from taking them back and allowing our receptors to hold on to them, then we have to understand that our patient's going to be at risk for a heightened blood pressure and a hypertensive crisis. I mean, look at here, too much tyramine, vasoconstriction, that's hypertension. We have too much norepi, we've increased our heart rate and blood pumping from the heart. That's going to increase blood pressure. You look at your epinephrine, increases cardiac output. You can see that actually, sorry, epinephrine is not part of your MAOIs, but you can see that these neurotransmitters and what they do are very important to understanding what these do for the body and the side effects that can occur in the body when patients take them. When we look at the EPSS with the use of antipsychotic meds, these are extrapyramidal side effects, and yes, we always stumble on those words. So let's take a look. Acute dystonia is going to be severe spasms of the tongue, the neck, the face, or the back. If there's a laryngeal effect, meaning near the larynx, it's a crisis, right? Because if we have laryngeal spasms, what's happening to our airway? That's right, it's closing. So we need to make sure we have rapid treatment for this. Usually occurs 5 days to a few hours after your first dose. And we'll say for the sake of conversation that you gave your patient some chlorpromazine or thorazine, and this was the side effect that you had. There's Parkinsonism or bradykinesia, rigidity, shuffling gait, drooling, tremors, usually occurs within 1 month of treatment. And I'm going to just come to this next page here so you can see some of the pictures that I'm talking about. Akathisia, you can see that it's unable to stand still or sit and continually pacing and agitated. This generally occurs within 2 months of treatment. And then we have tardive dyskinesia, TD. This might be one that you guys have seen in the hospital if your patients have been on antipsychotics. So they have involuntary movements of the tongue and face, lip smacking, speech disturbances or eating issues, involuntary movement of their arms and legs or trunk. And this can be permanent, and it usually occurs months to years after their therapy starts. So we need to think about what nurses need to do when they assess EPS symptoms. You guys can use the Ames test to assess for EPS, which you guys will definitely go more into detail in your mental health class. But we also need to understand that we can treat the symptoms with other medications, and we may need to lower the dosage of the current antipsychotic that they are taking, or switch to an atypical medication that can give us the same symptom or the same therapeutic outcome as the antipsychotic, but not have the same side effects. So make sure you review this and you guys know these signs and symptoms, that you can determine what your patient is showing signs and symptoms of, and then just general idea of how we fix that problem. Okay, next slide. The other two major side effects of antipsychotics are the neuroleptic malignant syndrome and metabolic syndrome. So metabolic syndrome is going to be in your second and third generation antipsychotics. So your first generation, give me 1 second here, guys. Your second generation antipsychotics, we're looking at like risperidone or risperidol. That's the other name for it. We have clozapine, olanzapine, and quetiapine or Seroquel. Your third generation is aripiprazole or Abilify. So just be familiar with those drugs, because if we ask you guys a question, your patient's on that medication, you need to understand that the side effect may or may not be expected for that drug. So if you look at my visual here, we have a bunch of questions here that I want you guys to be able to understand about metabolic syndrome. So what is your patient going to look like? Diabetes, weight gain, dyslipidemia, increased thirst, urination, appetite. What is the nurse going to do for this patient? Well, if you see either of these symptoms, NMS or metabolic syndrome, we need to stop the medication, tell the doctor, and treat the symptoms. So in this case, we probably need to make sure that we treat those glucose. We need to check the, well, in this case, it really is treating the glucose, because these are going to be all signs and symptoms of diabetes. If you look over at your neuroleptic malignant syndrome, your patient is going to have a lot more serious side effects. So you're going to have delirium, lethargy, possible coma, some autonomic dysregulation like tachycardia, tachypnea, drooling, hyperthermia, so high temperature, tremor, shuffling gait, severe rigidity. These are major side effects. And you need to put them on a cardiac monitor, get them a cool blanket or and Tylenol for that temperature, get them on some blood pressure medications. So once again, if I say that your patient is having neuroleptic malignant syndrome, and I say that your patient is hyperthermic, I need you guys to understand that you need to know how to treat that symptom. So you need to know what that symptom is, and then you need to know the treatment for it as well. Neuroleptic malignant syndrome is caused by first-generation antipsychotics, which are going to be your chlorpromazine and haloperidol, also known as thorazine for chlorpromazine, and haloperidol or Haldol. Go to the next slide. These are some considerations you guys need to have when you give psychotropic medications to your patients. So when do you tell your patient to investigate taking a medication for their problem? Do we wait until the patient has side effects in their life from the problem, such as their depression is so bad that they're not going to work? Well, the answer kind of is yes. We make sure that our patients go get medications for their problem when their issue or problem affects their daily life. So in the job, home, self-care, or ADLs. We need to make sure that we treat the issue and not just the symptoms. So your patients are going to ask you why are they on multiple drugs when they only have one issue. What do we tell them to help them to understand why they're on multiple drugs? Well, you guys know that your SSRIs are going to treat depression and anxiety. Many of these medications have multiple uses, and we as the nurse need to understand what those are so that we can explain it to our patients. The multiple use drugs have the action of those medication, they treat the different things. So we need to make sure that your patients understand that. CAM therapies and med-to-med interactions. There are a lot of interactions between psychotropic medications and CAM therapies. For instance, kava is a CAM therapy, and they should not mix their meds with kava because that can cause sedation when it's mixed with CNS depressants. Kava can also cause liver injury when it's used too much. So then if you give them kava with another medication that causes liver problems, now you've caused a higher increased risk for liver injury. Should also not mix St. John's wort, but you guys probably already knew that, right? Because we shouldn't mix St. John's wort with anything. Lots of patients, instead of jumping on board for their depression, a lot of, before jumping on like an SSRI or like, Zoloft, for instance, they'll take St. John's wort because it's great for depression as a CAM medication, but they should not take St. John's wort with their SSRI. So that's the teaching that we need to give to our patients. Tricyclics like TCAs and SSRIs like your fluoxetine and amitriptyline, if you take those together, they're going to get exacerbated. The effect of the TCA effect makes that medication more toxic. So we need to make sure that they understand that you cannot mix these medications. If the doctor writes the prescription, then and you guys verify that there are no contraindications, you have to understand what they interact with. So that way when your patient asks you, you don't freak out and say, oh my God, you can't take those together. Or you can say, okay, we should talk to the doctor about this. Another concept that you guys are going to see with psychotropic medications is a drug holiday. We all love holidays, right? Well, in this case, this drug holiday is a way for the body to, is a way for the doctor to actually assess to see, is the medication working for the patient? Can we decrease the dosage? Do we need as much as we're giving? And what it is that many of our drugs that have the potential for causing dependence, when used for extended periods of time, the drug holiday is going to be prescribed to reduce the drug dependence and assess the patient's condition. So it helps the patient to stay sensitive to the drugs so that we don't have to keep increasing the dosage as well. The drug holiday can be anywhere from a few days to a year or even more, depending upon the patient's reaction to it. 2 examples of drugs that we put on holiday: methylphenidate or Ritalin, also lithium. Now, I made this list for you guys so you can see all of your prototypes. This should look fairly familiar because it is the same list that your mental health uses. And I want you guys to understand the big umbrella, little umbrella, tiny umbrella concept. So anxiolytics is a giant big umbrella, okay? Antidepressants fit under that. And then antidepressants have their own tiny umbrellas. So the SSRIs, the SNRIs, the MAOIs, and the TCAs. These 4 classes of drugs all fit under anxiolytic and under antidepressants. Antidepressants are used to fix depressive disorders, OCD, bipolar disorders, and anxiety disorders. All of these antidepressants. So you can kind of group them together however your brain appreciates the most, but this is the most simple way for me to help you guys to understand this concept. Then we have our mood stabilizers and anticonvulsants. These are used for bipolar disorder. You have 4 medications: Lithium carbonate, your therapeutic range is 0.6 to 1.2. I always say this wrong, sorry. Carbamazepine, 4 to 12 micrograms. Lamotrigine and valproic acid, 50 to 120 micrograms. These are all of the therapeutic ranges for these 3 drugs. And your mood stabilizers are going to be used for bipolar disorder. Now we have our antipsychotic agents. Previously, we talked about neuroleptic malignant syndrome and what was the other one? One second, guys, sorry. And metabolic syndrome. So with this one, we're looking at what drugs fit under this category and what they're used for. All antipsychotic agents are used for acute and chronic disorders, acute and chronic psychotic disorders, schizophrenia spectrum disorders, bipolar disorders, generally in the manic phase, and then Tourette syndrome. So your first generation for your little umbrella for your antipsychotic agents is going to be haloperidol, fluphenazine, and chlorpromazine. These are the prototypes that you need to be familiar with. Remember, your first generation are going to have the NMS, so the neuroleptic malignant syndrome side effects, as well as those EPS, extrapyramidal, I can never say it, the EPS symptoms, I'm sorry. Okay, let's check the next slide. Your next big umbrella, once again, or this is the same big umbrella. So we have our antipsychotic agents. We just talked about the first gen, so now let's talk about second generation. Second generation prototypes are going to be risperidone, clozapine, and olanzapine. Now these 3 drugs are under second generation. In your second generation medications, you need to be more familiar with the metabolic syndrome, like the signs and symptoms from diabetes, right? Your third little umbrella that's under antipsychotic agents is going to be the third generation medications. And the one we need to focus on is aripiprazole. Have you guys heard of Abilify? Does that sound familiar to anybody? Abilify is a third generation antipsychotic. And we use this medication in our patients. They can cause some EPS effects, but generally you're going to look for the metabolic syndrome as well for this antipsychotic class. Okay, let's go to the next umbrella, CNS stimulants. So this is the big umbrella, right? There's only 2 things that fit under there. So these are your agents for ADHD. They're used for ADHD in children or adults. Your prototypes are methylphenidate, which is Ritalin, or amphetamine or dextroamphetamine. These are the 2 prototypes that you need to be familiar with for these drugs. And remember, we said that your ADHD medications, or methylphenidate, was one of those drugs that'll go on a drug holiday. Okay, so now we've reached the part where you guys need to do some work and determine what the action is of each medication class, what the major side effects are, the nursing considerations, and the patient education. So let's take a look at SSRIs. Think back to what we just spoke about, or what I just brought up to you guys earlier about neurotransmitters, and I'll give you. So what is the action of this medication? So it's going to allow more serotonin to stay in the symptom, right? What can we use? What do we use SSRIs for? For anxiety and depression, right? These are 2 of the main reasons why people are put on an SSRI. Benzodiazepines or benzos can be used for anxiety, but your SSRIs are going to be much safer for that. It tends to be a multi-use drug, right? So like our blood pressure medications and our erectile dysfunction, just like our blood pressure medication can be used as an erectile dysfunction medication. Do you guys know which one I'm talking about? The little blue pill? Viagra, yes. Viagra is a blood pressure medication, but it is also used as an ED medication. So your SSRIs can be used for both anxiety and depression. Some major effects or nursing considerations for this drug, safety, right? The biggest side effect of this drug is suicidal thoughts and decreased libido. Now, why is decreased libido going to be a major side effect? Well, what's one of the main reasons you think people come off of SSRIs? Decreased libido, exactly, or erectile dysfunction. Decreased libido and erectile dysfunction are the same type of thing. So anything where your patients don't want to have sex or can't have sex are going to fall underneath that category. And that's a huge reason for people to stop taking a medication, because sex usually brings pleasure to a person's life and people want pleasure in their life. So this drug, part of your patient education is that it can take up to 4 weeks to start working, which means that your patients need to understand that they may not feel the benefit of the medication for 4 weeks. Now, let's think of a medication where we generally start it early, or we start it where it might take a while to get into the system. If something takes a little while to get into the system, can we just stop it cold turkey? No. So your SSRIs must be tapered. Remember taper from prednisone? We had to slowly lower the dosage before they could completely come off of it. If your patients do not taper their SSRIs, it can lead to withdrawal syndrome, which would look like nausea, sensory disturbances, anxiety, tremors, unease, and malaise. This is not a good thing. We need to teach our patients that if you want to come off the medication, you need to talk to your doctor, and they need to do it the right way. Do you think that SSRIs interact with other medications? Yes, and there's multiple drug-to-drug interactions for this type of drug, so we need to make sure our patients are aware that they need to tell their doctor what medications they're on. All right, let's move on to TCAs. TCA stands for tricyclic. Come on, I know you guys know this. Tricyclic antidepressants. Very good. Okay. So a tricyclic antidepressant is going to block the norepi and serotonin, which is going to intensify or block the norepi and serotonin reuptake, right? Which means we're going to intensify the norepi and serotonin. And we learned that your serotonin is part of the pleasure, or serotonin is going to help decrease emotions, or it's going to plays a role in the mood and the emotions, and that your norepi is going to help to increase that heart rate and blood pumping from the heart, right? But that also it's going to help your brain to focus a little better. So this is really good. TCAs are good for depression, but it is not the first line medication. So a major side effect that can occur from a TCA is orthostatic hypotension. We get what are called anticholinergic effects. So do you guys remember from, I'm sure you guys probably learned this in patho, but anticholinergic is can't see, can't pee, can't spit, can't SHIT, okay? So the anticholinergic side effects of this medication are dry mouth, blurred vision, tachycardia, constipation. Your patients are going to have poor renal clearance with this, especially in our older patients, and a side effect of that would be they would have drowsiness and sedation, more so than other people. So we need to make sure that they are familiar, or that we are familiar with their renal labs before we put them on this medication. If the patient is taking too much or gets too much of this medication, they can get something called a cholinergic blockade, which is cardiac toxicity. So they'll get dysrhythmias, seizures, agitation, and death. There are multiple drug-to-drug interactions with TCAs. We talked about one earlier, but I'll remind you guys. So St. John's wort or an MAOI mixed with a TCA will lead to serotonin syndrome. Serotonin syndrome can occur 2 to 72 hours after they take the medication. Some signs and symptoms include confusion, anxiety, hallucinations, jerky muscle contractions or myoclonus, diarrhea, vomiting, tremors, fever, hostility, coma, and it can even lead to death. TCAs will take 10 to 14 days to start working, but the maximum effect won't even be seen until 4 to 8 weeks. So if your patient had a choice between going on an SSRI and a TCA, which one do you think they would prefer? Yes, technically an SSRI is going to work faster and it has less severe side effects, right? Very good. All right, next slide. Now we're going to talk about MAOIs. Now remember, I mentioned this earlier, where they block the MAOI enzymes in the brain, meaning we've increased the uptake of norepi, dopamine, serotonin, and tyramine receptors. What do we have to watch for? Think about it. I talked about it earlier. Yes, we need to watch for heightened blood pressure and hypertensive crisis. We have to make sure that your patients that are on MAOIs restrict certain dietary and certain medications to reduce the risk for these side effects. We need to make sure that they don't eat too much tyramine. So, what foods have tyramine? Strong aged cheeses like Swiss, Pharm, cured meats, pepperoni, summer sausages, alcohol, soybeans, and fermented foods. If your patient is on an MAOI and they consume too many foods like these, they can end up with hypertensive crisis. How do we know our patient is having a hypertensive crisis? What signs and symptoms will you see? A headache, nausea, increased blood pressure, increased heart rate. This could lead to a stroke. In order to fix this problem, we're going to give a medication called phentolamine, and it's going to be given IV, and we need to make sure that we watch for cardiac rhythms and respiratory support. This medication is going to take 2 to 4 weeks to work, but it's not used as frequently due to the side effects and the adverse effects of it, especially because patients like to eat those foods that I mentioned. So once again, tyramine-rich foods are strong-aged cheeses like Swiss, Pharm, cured meats like pepperoni, sausages, alcohol, soybeans, and fermented foods. Anxiolytics. Yes. So anxiolytics. This is the class that I was telling you fits. There's a giant umbrella that fits under them. And there's a couple medications, and this can get very confusing, so try to understand. Your medication, like buspirone, is an anxiolytic. And it's going to be used for panic disorder, social anxiety disorder, OCD, and general anxiety disorder. Buspar, it takes 2 to 4 weeks to work, and it is not a PRN medication, and it must be scheduled. They need to take this with meals to decrease nausea or GI upset, and you don't have to worry about withdrawal or dependence with this medication, and they must take it as prescribed. Now, if we go to this next here, your benzodiazepines, which also fall under anxiolytics, we have our Ativan, Xanax, and Valium. Now, everybody probably thinks, oh, yes, I know those. I'm very familiar with those. Maybe you've seen them used in the hospital. Maybe you've seen them, maybe you've used them yourself. Ativan is under anxiolytic and benzodiazepine. The umbrellas can get a little confusing, so I want to try to clarify that a little bit. So if we are talking about anxiolytics, like your benzos, these are going to enhance GABA in the CNS, and it is a very rapid effect. This medication works quickly, and GABA is your calming neurotransmitter. So if I am going to enhance my calming neurotransmitter in my central nervous system, what do you guys think the expected reaction for this is? Well, we're going to use them for patients that have seizures, alcohol withdrawal, muscle spasms, trauma, and we can use this for induction of amnesia as well, okay? We will use Ativan IV to help prevent complications from alcohol withdrawal, so that's something to be familiar with. If your patients come in with ETOH, they will be put on a scale, and if they, during your assessment, if they meet the requirements, they will be given Ativan IV. And the dosage is dependent on what assessment you do. So let's look at, okay, so what happens if your patient has something called a paradoxical response? A paradoxical response is going to be the opposite of the response that you want. So in this case, if your patient is given Ativan and they turn out and their response to it is excitation, euphoria, more anxiety, or rage, we need to tell our doctor because we shouldn't give this medication to our patient. What happens if this patient gets too much Ativan, Valium, or Xanax, or benzodiazepine. Respiratory depression, severe hypotension, and cardiac depression can occur. If your patients have toxicity from a benzodiazepine, we need to give flumazenil to reverse the adverse effects. Do you think your patients will get withdrawal from a benzo? No, you're correct. It's not common when they have when they're using them short term, right? If your patient is taking high doses of benzos regularly, do you think you need to taper them? Absolutely. It needs to be dosed, or it needs to be tapered over a few weeks when we do that. If you are giving this medication for amnesia, do you think that sedation and decreased cognitive function would be a normal or an expected effect for your patient? Yes, exactly. If they're using it for amnesia, your patients might actually have difficulty recalling events after dosing, usually used for bedside procedures. So Valium is great for that. Okay. All right, let's go to the next slide. Non-benzo CNS depressant. So if I am a non-benzodiazepine CNS depressant, what do you think I am going to be doing to my central nervous system? If I'm depressing it, what can happen? We're going to enhance the GABA. So we are going to enhance the calming center in the CNS, and it's going to help increase sleep duration and decrease awakenings. So our one and only Ambien, right? You guys know what Ambien is. You guys have heard that. Ambien is a medication that we give if our patients are having trouble sleeping. It has a low risk for tolerance, substance use disorder, and dependence. Now, I know you guys probably have personal stories that indicate otherwise, but it is a short-term management of insomnia. So if someone were to take this long-term, then they may see the other effects. You need to give it at bedtime, about 30 minutes before bedtime, and it should work for about 8 hours, which is generally what we want our patients to sleep for. They need to take it on an empty stomach because more absorption will occur. Patients that are pregnant should not take it while they are pregnant or breastfeeding. This is a pregnancy risk category C drug. They should take it cautiously in patients that have liver, kidney, or respiratory problems, because if our patients have respiratory problems, do we want them having a lower, or do we want to increase our GABA or enhance our GABA, which helps to calm us? It might slow their respirations down. Should they take Ambien with alcohol, which is also a CNS depressant, or other CNS depressants? I hope you are shaking your head because the answer is no, no alcohol or other CNS depressants. If your patient is taking Zolpidem, we need to be familiar with other CNS depressants, right? Because your patient may say, oh, hey, I'm on Zolpidem, and I'm also taking a medication called alprazolam. And you guys will learn that alprazolam is a CNS depressant. And if that occurs and your patient's taking both of them, there are some serious side effects, which we will discuss. Sorry, we don't, so back to what I was saying. So CNS depressant like alprazolam, you have like orthostatic hypotension and dizziness, right? And decreased respirations because I am decreasing my central nervous system, my CNS, right? So we just talked about non-benzo CNS depressants. Now let's look at our CNS stimulants. All right, so if my depressants are enhancing GABA, which is my calming effect, what do we think my CNS stimulant is going to raise the levels of? Yes, your norepi and your dopamine, your pleasure and your pleasure sensor in your brain, as well as it's going to increase that your heart rate, right? Your heart rate. So it's used for ADHD. These can be used for obesity and narcolepsy as well. Major side effects: decreased appetite, weight loss, growth suppression. So patients that are taking these when they're kids, we really need to watch for this, because if they're losing weight and they're not growing appropriately, it could be due to this medication. We need to make sure we give this med early in the day, no later than 4 p.m., because it can actually cause insomnia in your patients. Some major side effects are dysrhythmia, chest pain, and hypertension. So we need to watch this in patients that have heart problems because we could cause sudden death in them. So if you have an adult patient or a younger patient, a child who has cardiac issues, we need to be very careful because we are going to be raising the levels of norepi, which is going to increase the heart rate and blood pressure, right? How do you assess for dysrhythmia? Very good, a 12-lead EKG, very good. An adverse effect of this medication or patient education, if they have a psychotic effect to this medication, like hallucinations and paranoia, they need to stop the med and call their doctor immediately. This is not good. If they get withdrawal from the CNS stimulant, they're going to get a headache, nausea, vomiting, and depression. And once again, this would mean that they took the medication or that they stop the medication cold turkey. This is another medication that we need to make sure that we taper. So we need to use the medication with therapy, cognitive behavioral therapy to help improve outcomes. This is one of those medications, and honestly with all psychotropics, except for like your antipsychotics, I really want you guys to think about how your patients can kind of rewire their brain a little bit and then learn the behaviors that they need to be able to eventually come off of that medication or taper from that medication. So this medication is going to be scheduled and prescribed, but if your patient is getting better because they have been doing extra therapy, we need to make sure we taper them off of it and that they need to stay going to or they need to continue going to their therapy to continue to get the benefits from it. All right, last but not least, antipsychotics. All right, here we go. I want you guys to notice in this picture that your antipsychotics can be given IV. Here you got chlorpromazine and Haldol. They can be given in tablet form, and they can be given in suppositories. So there's many different ways that these medications can be given. Not just IV, also IM. So we tend to give Haldol IM. It's fast acting when we do it that way. And if your patient is agitated and stuff and they don't have an IV, it's pretty easy just to kind of find that muscle and, stick it in there. All right. So we use these antipsychotics, like I said before, for a lot of different reasons. Schizophrenia, bipolar for the manic phases, pretty much any psychotic disorder. And once again, you guys are going to go into much more depth of these disorders in mental health. So please bring that information to your pharmacology course. Okay, so the meds are going to treat positive manifestations related to behavior, thought, perception, and speech. So like bizarre delusions, hallucinations, flight ideas. Those are your positive manifestations. Your negative manifestations are going to include social withdrawal, lack of emotion, lack of energy, flat affect, and decreased motivation and pleasure in activities. So they are going to treat both positive and negative manifestations. And once again, you guys are going to get into that a lot more in mental health. So your first gen is going to focus, your first gen antipsychotics are mainly going to focus on your positive manifestations. So Thorazine is a low potency drug, Haldol is a high potency drug. Those two are going to be used to help focus on positive manifestations like behavior, thought, perception, and speech. The biggest side effect or patient education for this is those EPS symptoms. Remember we talked about those? The akathisia, the tardive dyskinesia, the Parkinsonism. You guys remember the last one? Acute dystonia, very good. So acute dystonia is your facial grimacing, involuntary upward eye movement, muscle spasms of the tongue, face, neck, laryngeal spasms. Your tardive dyskinesia is going to be protrusion and rolling of the tongue, sucking and smacking movements of the lips, chewing motion, facial dyskinesia, involuntary movements of the body and extremities. Akathisia, that's going to be the restlessness, right, of the legs, pacing the floor, trouble standing still, feeling in constant motion, rocking back and forth. And then of course, Parkinsonism, your pseudo-Parkinsonism is going to be stooped posture, shuffling gait, rigidity, tremors at rest, and the pill rolling motion of the hand. Your emergencies for your antipsychotics are the neuroleptic malignant syndrome. So your patient is going to show a sudden high-grade fever, high blood pressure, diaphoresis, muscle rigidity, dysrhythmias, tachycardia, change of level of consciousness, and coma. We must stop the med and treat the symptoms. So once again, if you don't know what you do for a high-grade fever, you need to understand what we do, which is cool the body and give them some Tylenol, right? High blood pressure, give them some meds, lower the head of the bed. Dysrhythmias, we're going to put them on a cardiac monitor. We're going to give them some medications for that. So really understand how you treat these symptoms. And I just noticed that I didn't mention what the action of the medication is. So the action of this medication is going to be, it's going to block the reuptake of the dopamine and acetylcholine, histamine, and norepi in the brain and the periphery. So it'll just go to the receptors, so your patient will have a lot more of those things. Okay, move on to our second generation antipsychotics. So these are going to block serotonin and dopamine, but to a lesser degree. It's also going to block the norepi, histamine, and acetylcholine receptors too. So we can use these for schizophrenia spectrum, bipolar, impulse control disorder. Antipsychotics that are second generation have good relief of positive and negative manifestations. Do you guys remember the difference between the two? So positive effects are going to be related to your behavior, thought, perception, and speech, bizarre delusions, hallucinations, flight ideas. And your negative manifestations are going to be like social withdrawal, lack of emotion, lack of energy, flat affect, decreased motivation, and pleasure in activities. And your second gen will relieve both the positive and negative manifestations. It should help to decrease depression, anxiety, and suicidal side effects and poor memory. And there are fewer or no EPS symptoms because we have less dopamine blocked, which also means that this is not going to, your second gen antipsychotics will not cause tardive dyskinesia. So two things I want you guys to hear. Olanzapine or your Zyprexa has a very high risk for metabolic syndrome. So your adverse effects of this medication is going to be sedation, orthostatic hypotension. Your clozapine is going to have lots of adverse effects. This is not the first line antipsychotic prototype that they would recommend. It can cause agranulocytosis, where your patient doesn't make enough white blood cells. So we need to monitor their white blood cells and watch for fever and other signs and symptoms of infection when they're on this one. Your Seroquel has a moderate risk for metabolic syndrome, and it has the same adverse effects of the olanzapine. And with your Seroquel, they need to get an eye exam every 6 months. When you look at Abilify, the main thing about your Abilify, it can cause metabolic syndrome. It can have some EPS side effects, major adverse effects, sedation, headache, anxiety, and GI distress. We're almost done, guys. I only have 2 more slides. You're doing great. Let's talk about mood stabilizers. Now, this is going to produce a neurochemical change in the brain. This is used for bipolar, acute mania, and helps prevent return of mania or depression. This is not a first-line medication because it has a very narrow therapeutic window, which means that they must monitor the blood levels closely. Blood levels should be drawn 10 to 12 hours after the last dose when we're changing the dosage, and every 4 to 5 days. Lithium toxicity, your levels are going to be above 1.5 to 2.0, and it's going to be ongoing diarrhea, nausea, vomiting, mental confusion, poor coordination, and sedation. We must tell the doctor and promote the excretion if it's severe, or they need to give a new prescribed dose. But do not give the medication if your patient is already, if that therapeutic level is above what it is supposed to be. This is a pregnancy D category drug and definitely should not be given to patients that are breastfeeding. The effects of this drug, some basic side effects that you'll see: nausea, diarrhea, abdominal pain, fine hand tremors, polyuria, weight gain, and renal toxicity. So we need to know if our patient is having toxicity where it's ongoing diarrhea, nausea, and vomiting, or are they just having a basic side effect like nausea and diarrhea and fine hand tremors. Okay. Talk about mood stabilizing anti-epileptics or anti-seizure medication, right? So These are used to treat bipolar and manage the symptoms of relapse for mania and depressive episodes. They're going to suppress the CNS excitation, so your central nervous system, and it potentiates your GABA, so it helps to kind of slow things down. So it's going to suppress the thing that makes you excitable, and it's going to potentiate or increase your GABA. We're going to look at our I can't say the word, I'm sorry, carbamazepine or Tegretol. Okay, so initially, this will subside in a few weeks, but initially, nystagmus, double vision, staggering gait, and vertigo can occur. So we need to give low doses at bedtime. It increases the risk for fluid overload. So we need to watch in our heart failure and kidney patients. It is also hepatotoxic, so we need to monitor for bone marrow suppression and bleeding disorders before we give this medication, meaning if they have it, we really should not be giving these medications for it. These people should avoid driving when they take this medication, and this is also not good for our pregnant people. Leukopenia, anemia, thrombocytopenia, like bleeding gums or a sore throat, report to the provider. These are all adverse effects, and we need to make sure that the provider is aware. A big one for these is Stevens-Johnson syndrome. It's a painful rash. They get flu symptoms and the blisters. This can be life-threatening. This is an absolute emergency to tell your doctor. For Depakote, note that it is hepatotoxic. We don't give it to pregnant people, and it can cause, it has more serious effects in people with pancreatitis. Your Lamictal can cause headache, dizziness, blurred vision, nausea and vomiting, and Stevens-Johnson's as well. So just be familiar with those medications as we've talked about with the other medications. This is the last slide for this presentation. Please fill out the PowerPoint. And then I am going to also be handing out a mental health Pharm 1 psychotropic drugs chart, if you will. I think I'm going to actually post that for you guys, so if you want to start on that, you're more than welcome to. If you have any questions, please feel free to reach out, and I hope this was helpful. Have a good day, guys. Bye.